workshop, so we have collected few cases for you. Okay, so this is the yeah. Okay, so this is the gastroesophageal junction area. Dr. Sandeep Dote sir has shown you how to look for the normal gastroesophageal junction between liver and the aorta, and this is the thickened esophagus here. One more case where you see that the esophagus is eccentrically thickened. The posterior wall is more thickened than the anterior wall, that is the air within the esophagus, and the transverse section you can see that the mass in the GO junction area. So these are very subtle and silent lesions most of the times. Unless patient presents significant dysphagia, the patient don't come to the clinician. So it is always good to look for the gastroesophageal junction while you scan the epigastrium. This is an example of hypertrophic pyloric stenosis. You can see the thickened pylorus. It is almost looks like a mass, and this is long section, and with the reverse peristalsis in the stomach is very well demonstrated. We'll see this again. More than 3 mm of single wall thickness, and more than 13, some call it more than 15 mm in length. That is the criteria for diagnosing of hypertrophic pyloric stenosis. So we can use high frequency probes to better delineation. In earlier days we have diagnosed this with convex probes also, but with newer probes and newer technology, it adds to your confidence. The peristalsis normally is in one direction, and in obstruction, as you see here, the peristalsis is occurring on both directions. It's to and fro. That indicates that there is an obstruction, and in this case you can track or trace the small bowel loop distally to find the level of obstruction. So ultrasound, yes, definitely can give you a better idea about the dynamic changes that are occurring in the bowel. This is a patient with passage of intermittent loose stools, no other complaints. And what you see here, this is the jejunal loop in long section, and this is in transverse section. So within the lumen, there is a tubular structure that is showing in alternate hypo and hyperechoic areas, multiple layer like thing. So this nowadays you don't find this, but we used to see them in last decade or so in many patients. That is a worm in the small bowel loop, and sometimes they conglomerate at one place and they just form a mass like thing and may cause obstruction also. So that possibility should be taken in mind while doing ultrasound also. Simple colonic inflammation that can cause wall thickening. It's more than 5 mm here. It is circumferential, evenly placed on both sides. There is some fluid in the lumen. That is the reason you are seeing the all walls nicely, and you can see the gut signature very nicely here. So we have seen some examples of thickening also. This patient came with pain, and on ultrasound, this is a large bowel in long section. You can see it's all air filled, but in all of the colon you can see that small hypoechoic lesion with a cystic area, a couple of cystic areas. We kept him at cystic, but see, this is again a type of thickening. Was very sort of type of sometimes differentiate between neoplastic and inflammatory can be diagnosing lesion. We have so many bowel malignancies that are never suspected, because the colonic malignancies, unless they cause obstruction, they don't produce any symptoms apart from dull pain. So seeing the colon into abnormal. Peritoneum momentum. The momentum is normally thin, but you can see thickened momentum of malignancy having multiple deposits. Sometimes in the peritoneum you can get multiple cystic lesions. This is one of large cyst, and there are multiple small cysts everywhere, and you can see that the fluid level is there. There is deposition of this echogenic thicker internal echoes. They have formed a level, and there are thin internal echoes above that. So this was the case of peritoneal hydrated cyst also. Then sometimes the free fluid in the bowel becomes very much thick, and it's all around the bowel loops. It forms a sort of layer around the all structures in the abdomen. Like you see here, very thick internal echoes are seen in the fluid, and that's that we call it as a pseudomyxoma peritonei. And the momentum is slightly thickened here in the superior part. Normally you don't see momentum, but the momentum is sort of inflamed with ascites. On tapping, it turned out to be tuberculosis ascites. Then ascites can have varied features. Here you see this ascites has got multiple lace-like echogenic bands, very thin bands across the ascites, and there's a lacy pattern there. It's covering all the small bowel loops, and it has displaced the small bowel loops inferiorly. So they are air cutting, they are not coming up to here. Usually in routine ascites, the exudative ascites, you see the bowel loops, they will come, they will move ascites also. But when the ascites becomes organized like this one, thick and with septations like this, then the bowel loops are at one place, and then you this is quite commonly seen in tuberculosis. Always also that is called as cocoon in earlier days. Bowel, if you do barium of these patients, you will see small bowel loops conglomerated in the center by this thick septate ascites. Then can be blood in the peritoneal cavity, and you need to find the source. Like you see here, there is splenic hematoma, and that has probably outside or outside the splenic capsule, and there is a significant amount of fluid with internal echoes peritoneal cavity. Free air pneumoperitoneum, as Dr. Sandeep has demonstrated, informed you how to look for the free air. You can see them in the epigastrium, you can see in the hypochondriac region between the abdominal wall and the liver. Whenever a bowel loop is touching the interabdominal wall, you will see the wall in between the bowel loop and the air. So this thin streak will be always seen whenever there is a bowel loop touching the interabdominal wall. Whereas when you see this air is free air, the free air echo that will be touching the aponeurosis posteriorly of the rectus, behind the rectus, and you don't see a hypoechoic rim or hypoechoic bowel wall there. So that is how you differentiate. This is the pneumoperitoneum that is typically seen in between the interabdominal wall and the liver. You can see that air with reverberations. This is again air everywhere. So that pick up pneumoperitoneum, though we always do abdomen standing X-ray. Investigation or surgery may be advised. Various pathologies, neoplastic lesions. or more than half of length, that is taken as abnormal. In children, 8 millimeter short axis length is taken as abnormal. These are various examples of genetic nodes with normal echo texture. They are showing the hyperechoic center, and this is how you can see the vascularity within the nodes. The single hilar vessel, regular branching, and reaching up to the periphery. So all these indicates these are the inflammatory lymph node enlargement in the mesentery. The artery is seen in the center. This is a case of malignancy where you see multiple mesenteric metastatic lymph nodes. They are, if you compare with the earlier slide, they are all more dark, and some are some or most of them, they do not show any hilar echo within them. So in the light of known malignancy, this is taken as metastatic lesions, but tubercular lesions also can produce similar. So we can further investigations. That is the suprarenal mass, solid mass. Again, same patient came for evaluation of kidney. In the gross patient had a large suprarenal mass. It was on the or the umbilical linear. You can see the hernia and how the what are the contents, what is the size of the defect. You can mention it in a report so that they decide the size of the mesh that has to be put, and we can also label whether the hernia is reducible or irreducible, where the neck is narrow and the body or the sac hernia is wide. These are the ultrasound over other modalities. You make the going. This is the case where there was a swelling in the umbilicus thought to be hernia, but patient had pain and tenderness also. So this is ultrasound and launch section and transverse section. So this is all within the umbilicus, a hypoechoic area, little heterogeneity is there. But you can see that the linea alba is maintained. This is all in the umbilicus, so there is no herniation there. And Doppler showed increased vascularity. So chronic inflammation, granuloma. On dynamic sound or bear down. On color Doppler also, the epigastric direct hernias, they always move anterior, and they have eight in the Hasselbalch triangle. They appear directly in the Hasselbalch triangle. That is the reason. Indirect, they come indirectly. So therefore they are called indirect hernias. So this is an example of indirect hernia. That is a long section, and you can see the internal inguinal ring. That is the section of the internal inguinal ring. So once we identify the ring, you can always elicit these maneuvers to look for the hernia. The indirect hernias, they will slide from lateral to medial epigastric origin, then may reach scrotum if they are large, whereas direct hernia tend to be localized or some to the inguinal canal. If you see, the indirect ones are superior to the cord and direct ones are the inferior to the cord. This is the example of Spigelian hernia. A large defect of size more around 4 centimeter is seen, and the contents were protruding outside. This was confirmed on CT scan also. You don't have to see these Spigelian hernias quite commonly, but even incisional hernias are also seen sometimes, but patient usually comes with the complaint that swelling at the site of the surgery. This is how the femoral hernia looks, as I have told you, that is just superior to the insertion of vein into the common femoral vein, and just medial in the femoral triangle you can see this femoral hernias, and that are the reason of groin pain or lower abdominal pain in females. So it's not very uncommon to find femoral hernias as per the